Hello, everybody. Welcome to the September RDLA webinar. I'm going to give everyone just a second to get logged in, and then we will get started. Great. Let's go ahead and get things kicked off. Again, thank you all for joining us for the September RDLA webinar. It's good to be back with everyone after taking a break during August for Rare Across America. But we are coming back with a very exciting webinar for you guys today. So thank you for joining us. Before we get started, I have a couple quick reminders for you all. If you prefer to call into today's webinar, you can do so using the phone number and the webinar ID listed on the screen. As we go through the different presentations, if you have questions you would like to ask the speakers, please type them into the Q&A box and a member of our team will direct the question to the speakers. And if we have any media joining us today, we ask that you formally announce your participation and refrain from quoting any of this discussion during the webinar. We instead encourage you to follow up with participants afterwards for direct quotes. We also have closed captioning available for all of the RDLA webinars. You can use it by clicking the live transcript button at the bottom of your window. We also have Spanish translation services available. Bailey is going to put that link in the chat for you all. So if you're interested in viewing the live English to Spanish translation of the meeting, you can just click that and it will pull up for you. Now, our agenda. So we are going to kick off the webinar today with Annie Kennedy from the Every Life Foundation for Rare Diseases. And Annie is joining to tell you all a bit about the cost of delayed diagnosis in rare disease, which is a health economic study that our team has been working on. Next, we will have Dylan Simon with the Every Life Foundation for Rare Diseases, who is joining to speak about a newly released newborn screening white paper. And then following that, we have two amazing speakers for you all who are going to talk about current federal legislation that you can advocate for using the data and information that Annie and Dylan are sharing. So first, we will have Molly Ford with the National Society of Genetic Counselors joining us to talk about the Access to Genetic Counselor Services Act. And then last but not least, we have Megan Anderson Brooks from the Innovation Policy Solutions. And she is going to be giving you all more information on the Precision Medicine Answers for Kids Today Act. So Annie, I will go ahead and kick things over to you first.
Great. Thanks so much, Caitlin. And hi, everybody. Thank you so much for being here with us today for this really important RDLA webinar during Newborn Screening Awareness Month. So thank you to everybody for all of your advocacy efforts that you do throughout the year to help eliminate and reduce the diagnostic odyssey for those who we care so much about in our rare disease community. I'm really excited to share with you the findings from a study that so many of us in the community have been working on for the last 18 months, which followed on the previous national health economic study that we as a community had led together. So I'm just going to provide a little bit of background for how we got to the study. So we can go to the next slide. So everybody here, I'm sure, remembers and is familiar with the first study that we as a community put out, which was really the first time that we were able to transform the lived experience of rare disease into data that was really helping to shift the conversation and the considerations around what it means to live with a rare disease in health economic terms. And really importantly, what this data showed, which was not surprising to any of us in the rare disease community, was that the lion's share of the costs incurred in living with a rare disease are those being shouldered directly by families and society. They are not the costs in those red bubbles here. The costs in the red bubbles are the direct costs, and the costs in the purple and the orange bubbles are what we refer to as the indirect and non-medical costs, those costs that are not reimbursed by the healthcare system, but still are hard costs that have to be paid for by somebody, and more often than not are paid for directly by families. So if we can go to the next slide. But what we knew when we did this study is that those costs, that trillion in 2019 that we uncovered was really just the tip of the iceberg, that we were just starting to look at what those costs were, and that there was so much more that lay beneath the surface that we needed to begin to chip away at and understand. And one of those things that we had looked at when we developed that study is, if you'll recall, many of you here, I'm sure, participated in that study. One of the ways we conducted that study was by conducting a survey, and we worked with the broad patient community to develop the survey elements that we included in that study. And that survey included findings around the diagnostic odyssey in rare disease. So if we go to the next slide, I'm sure anyone here probably doesn't need for me to define the diagnostic odyssey, but I feel like it's important that we do, because it's not a term that everyone outside of our rare disease community understands. But the diagnostic odyssey is that time point between when you or your loved one first realizes that there's something going on, and you first seek expert medical guidance to try and get to the diagnosis, and then the time point at which you have a confirmed diagnosis. And the diagnostic odyssey is everything that happens in between. And while this image looks like a windy, bendy road, what we really know in rare disease is that the diagnostic odyssey oftentimes has no finite start and no finite end. And for many of us, often looks more like a game of chutes and ladders, with lots of starts, stops, false hopes, and then dashed hopes. And while this study really captures a finite diagnostic odyssey for many within the community for whom there is a targeted screen and an ability to get to the end, we also understand that the study and the findings I'm going to show you are not representative of those within the community for whom there is not yet an end, for whom we don't have a finite diagnosis. So I just want to make sure that we are still working for those who fall within that undiagnosed category, but we needed to start somewhere. So let's go to the next slide. From our first study, that study that we published in 2022, what we found from those who participated in the survey was that the mean diagnostic odyssey of survey participants was 6.3 years and included over 16, so close to 17 providers. And if we go to the next slide, we even had a breakdown of what some of those medical interventions and providers included. So how many specialty physicians, geneticists, genetic counselors have been included, how many primary care physicians people had seen, how many emergency room visits and hospitalizations have been included, and how many out-of-state trips those diagnoses had included. And that really led us to want to better understand and go beneath the surface, back to that analogy of the iceberg, and understand what costs were involved in this diagnostic odyssey. So that's what brings us to this next study. So we can get on the next slide. So we embarked on understanding the cost of delayed diagnosis in rare disease. And we understood that to really look deeper into this, we couldn't look at the broad universe of rare diseases. We were going to have to look specifically at a couple rare diseases that we could build out as case studies to be representative of our broader rare disease community. So if we go to the next slide. So here's what we know about the diagnostic odyssey. We know that the diagnostic odyssey results in delayed and missed diagnoses. We know that delays in an accurate diagnosis can and does yield inappropriate clinical management, unnecessary medical interventions, and missed treatment windows for optimal therapeutic interventions, and that it yields the inability to optimize health outcomes for those of us in the community. And we also know that the diagnostic odyssey may contribute to the increased probability of irreversible disease progression and complications, which puts us at risk for preventable mortality and disability. But most importantly, and this will really relate to the other speakers here today, we have the technology to do better, and that we have advancements in technologies to screen, diagnose, and treat and manage rare diseases that can dramatically shorten and eliminate this diagnostic odyssey. So if we go to the next slide, we set out on a study that would help us develop some evidence to move policy to solve for the elimination and reduction of the diagnostic odyssey forward. So our study goal was to provide an estimate of the potential cost savings that may result from shortening or eliminating the diagnostic odyssey. We wanted to understand the patient journey prior to diagnosis, and then use those patient journey maps to quantify the medical costs and productivity losses of delayed diagnosis. So related to that, we worked with experts within the communities of the diseases that we decided to work with to develop very detailed patient journey maps. And those patient journey maps mapped out what a patient journey of what we defined as a timely diagnosis would look like in the pre-diagnosis period, the year of diagnosis, and in follow-up. And then develop patient journey maps of what that patient journey looks like when there's a delayed diagnosis, which right now is very often the reality for a typical diagnosis. And then we use those patient journey maps to drive the methodology for the study. And that's what allowed us to venture under the surface and look at the costs involved in the diagnostic odyssey. So next slide. So we published this report 2 weeks ago, and the report's available on our website with all of the data and all the findings. But for the sake of time, I'm going to just very quickly preview some of the data. And we can go to the next slide. There's a lot of detail about our methodology, and for the sake of timing, I'm not going to go through all of it, but I'm going to maybe highlight a couple things on the next slide. We did use data from Medicare, Medicaid, and a commercial data set, and we worked with OptumServe Lewin, the Lewin Group, who are our health economists that we worked with on this study. We selected 7 rare diseases, 5 of which were pediatric onset diseases, 2 of which were later onset, oftentimes adult onset conditions. And of the 5 pediatric onset conditions, 3 are already on the federal panel for newborn screening, known as the RUSP, or the Recommended Uniform Screening Panel. I already talked about the patient journey maps, and our methodologies included literature review, the development of the patient journey maps, and working extensively with an advisory committee who guided the entire study, and then experts within each of the patient communities who worked with us on understanding each of the diseases and the data that we were receiving within each of those diseases. We also did leverage the survey from the first study. So if you participated in the survey from the first study in 2020, that data was also incredibly helpful in this second study, because we did a calculation around productivity losses that you'll see in this data. And so we were able to use that data again. So we just want to continue to thank the community for just the powerful engagement in this study and in this health economic work. We are continuing to use your engagement. Okay, next. So what did we find? This is the way we calculated productivity loss. The reason I have this here, and I know that this is super technical, but I think it's really important for everyone to understand, is it's really important to us, because we use this data for policy purposes, that our data be what I refer to as bulletproof. So we have to anchor any calculations we do to published methodologies. But as you can imagine, there isn't often a published methodology already established for rare diseases. So we found one that the closest we could find had been established for premature infants. And we created a calculation that does a correlation between, if you had been inpatient in the direct cost data, it equals 1 day of missed work. Outpatient or emergency visit is half a day missed work, et cetera. Even with this calculation, we understand and feel very strongly that this is a significant underestimate of the productivity loss or the impact on caregivers and individuals living with rare diseases when you have a loved one who's in the hospital, or a loved one who is going to their regular routine clinic visit. But we understand this is just a start, but it's so important to us that we include these calculations in our data. But I just want this caveat here. We know that this is probably not an accurate representation of how much time is lost when you're navigating appointments or caring for your loved one. But it's really important to us that we start somewhere. So next. Okay, so just a high level overview of what we found. Because this is Newborn Screening Awareness Month and this is a newborn screening panel, I'm really just previewing the pediatric data, but the data from all 7 diseases is in the report. So what you're seeing here, and I recognize this as a complicated graph, but again, in the report, we have a description of all of this and an executive summary at the beginning that explains this really well. And then at the end, I'll show you there are some nice infographics that can also be downloaded online. That also has some really great images to help bring this to light. But what you see on the left are the costs associated with timely diagnosis. And on the right are the costs for each of the 5 pediatric onset diseases associated with delayed diagnosis. And these are the average costs per year. And you can see then how many years, that's the shaded area behind, each of those time periods typically takes. So what you see there is for ALD, Pompe, and SCID, those conditions are screened for in the newborn period. So there is no cost associated with timely diagnosis because there is no pre-diagnosis period. Babies are screened for at birth. Fragile X and Duchenne are not screened for at birth. So the average cost of timely diagnosis in those diseases as defined by those communities and those KOL groups, and you can see in Fragile X, the age of diagnosis was 1, and the age of Duchenne for timely diagnosis was 2.7, are listed there respectively. And then you can also see that on the right-hand side, starting with ALD through Duchenne, what the mean cost for each of those diseases is if it's a delayed diagnosis. So you can see what a difference it makes to be having a timely diagnosis in each of these diseases versus a delayed diagnosis. These are avoidable costs. If we go to the next slide, we also did calculations to look at this another way. So if we look at what the costs associated with newborn screening could be, we look at the 3 conditions for which we screen right now in the newborn period for ALD, Pompe, and SCID. For ALD, if we are not screening in the newborn period, the diagnosis at age 1 is close to $46,000 a year. At Pompe, the cost is $48,000, and SCID is close to $87,000 a year. Those are the avoidable costs when we don't screen in the newborn period. This is why newborn screening is necessary. Next. We also did, so this is where I'm talking about, we leveraged some of that data that we had from the first survey to do some calculations, looking at the out-of-state trips related to a rare disease diagnosis. And this is based on how long the diagnostic odyssey goes on. So in children, if the diagnostic odyssey is less than 2 years, on average, people were traveling out of state about 1.5 times to get to the end of a diagnostic odyssey. If the diagnostic odyssey was over 5 years, there were more than 5 out-of-state trips. Again, this has so much to do with whether or not insurance will reimburse. And we didn't even begin to do a calculation of how much it costs to travel out of state in order to seek a diagnosis. On the right-hand side, we did similar calculations for adults who were seeking a diagnosis and on a diagnostic odyssey and out-of-state trips. Next, and there's a lot of data to get through, and so I'm just highlighting it. And again, all of this is available on our website and in the report. So as I mentioned, we did some infographics to sort of frame this along with the patient journey maps and the patient journey. So if we can go to the next. So we pulled some of these calculations together for a couple of the diseases that we worked with. So this is just an overview of what we had done for Duchenne. And this is just showing the data another way. So if you look on the left, this is a stopwatch because time is a commodity in rare disease. And we really don't have time to waste when we think about navigating a diagnostic odyssey and eliminating irreversible disease progression. So if you look there on the left, that is the patient journey. If a patient has a delayed diagnosis. And on the right is a patient journey when an individual has a timely diagnosis. And what each of those dots represents are medical interventions, and they're color-coded based on whether they're medical interventions that are typically accompanying a diagnosis, testing procedures, specialists, treatments, and supporting therapies, and then events such as unexpected hospitalizations, et cetera. The number of dots increases by the number of times those interventions are necessary and based on the time period. Center circle is pre-diagnosis, middle circle is that the time of diagnosis, the year of diagnosis, and the outer circle is post-diagnosis time period. So you can see what a difference a timely diagnosis makes versus a delayed diagnosis. Similarly, we did a very similar mapping with Pompe disease. So you can see in Pompe what a difference it makes to have a timely diagnosis versus when there's been a delayed diagnosis. Again, we also pulled some numbers on the side of these infographics as well. And then one other infographic that I'll share is we mapped all of the diseases together to again show what happens when there's delayed diagnosis on the left versus timely diagnosis on the right, and what impact it has across rare diseases when we are delaying diagnosis and delaying implementation of tools that enable earlier or timely diagnosis in rare disease. Okay, so just a couple things I'm going to flag because these study limitations are policy implications. There are a lot of challenges in using ICD codes, and as many here know, of the estimated 10,000 rare diseases, there are just over about 500 ICD codes in rare. So we need more ICD codes in rare disease. Majority of rare diseases have significantly longer diagnostic odysseys than those that we've talked about here. So, and these findings are extremely conservative. So we're just getting started on this data. And then, as I already said, the productivity loss methodology is extremely conservative. But this data is an important start to talk about what the avoidable costs are in the diagnostic odyssey and how we can do better by our rare disease community. So I just want to end with a couple slides that thank all of the partners who worked with us and supported this study. These were our study funders, and if we go to the next slide, it shows all of the individuals who worked so hard to serve as advisors across our stakeholder ecosystem. And the next slide shows all of the experts within the partner communities who made sure that we got the data right for their respective rare disease communities. And that's it for me. Thank you.
Great, thank you, Annie. We have a couple questions for you in the chat. Someone asked, we all find the argument for newborn screening convincing, but we also know that people will ask, where do you stop? Is the RUSC criteria what should be held up as the standard?
So why don't we, that's such a great question. And I think maybe we do that question after everybody's presented, because I think Dylan's presentation will help address some of that, and then we'll come back and maybe that would be a good discussion question for everybody, because I think Dylan's going to help address and answer that question a little bit. But that's awesome. A phenomenal question, and keep the name of whoever asked that because we might want them on a committee somewhere.
It was an anonymous person, but they.
Well, if you came in as anonymous, maybe drop your name in the chat or email Caitlin and tell them who you are.
Awesome. Thank you so much, Annie. Great. Okay, we are going to move to Dylan. So Dylan, I will pass things over to you to talk about the newborn screening white paper.
Thank you so much. So I'm happy to talk to you a little bit around the newborn screening side of some of the work that we've been doing. And so as we were able to publish on September 6th, a new white paper that really looked at how we can modernize newborn screening overall and really look at how can we continue to grow the program as the innovation around newborn screening continues to grow. And so what we started looking at was, at the beginning, was talking about some of the challenges. And next slide, please. And so you see here on the right side of the screen that in a recent survey conducted by RTI International, when asked if even a small change was needed, 100% of survey participants from across the newborn screening ecosystem agreed that at least a small change was needed. Within that survey, just under 50% said a large portion was needed. And the reason I want to highlight that is because it highlights the fact that across the newborn ecosystem, whether it's academic, state lab directors, patient advocacy organizations, or industry, we know that change is required with newborn screening to address some of the challenges you see on the screen in front of you. There are limited federal evidence reviews. We know there are disparities across state lines. That some states screen for 31 of the Rust core conditions, some states screen for 37 of the Rust core conditions, and there's a lot of variation among that. We also know that there are challenges in implementing new conditions, that it can take on average 5 to 6 years for a state to add a condition once it's been added to the Rust. And even outside of Rust conditions, we know there can be a challenge for states to implement new conditions. We talked a lot around the use of genetic testing within newborn screening within the roundtables. And there was a lot of conversations from state lab directors who said, we would love to implement genetic testing, we just don't have the capability of doing so. And so we really want to address some of these challenges, as well as acknowledge that there is limited state and federal funding, and how do we work to address some of those issues. And so with these challenges in mind, we worked with a collection of stakeholders within the space, next slide please, and really brought the newborn screening modernization roundtables together. So these occurred last year over the course of the summer, and it was really a community effort. So you see here on the right that it was a collection of organizations who really work hard in the newborn screening space, or leaders within the newborn screening space, came together to develop what these roundtables would look like. And what it culminated in was this idea that we need to ensure the fact that we're talking to the broad community. So we held 3 roundtables, the first of which was a public meeting, but then the second and third of which we brought in specific experts. Again, we were looking at academic researchers, state lab officials, patient advocacy organizations, industry partners, federal partners, to really look at, or as well as physicians, to really look at making sure that we were talking to everybody, making sure that we heard the expertise from across the ecosystem. Because what we didn't want to occur was to develop a list of actionable policy solutions that once we published a entire collection of partners within the space would say, well, we just can't do that. That is not possible. So we wanted to make sure we were addressing these issues. And so that really culminated in 4 key themes. But I want to dive a little deeper into some of how we got there. And so next slide, please. And so we really broke it into 3 roundtables. And so the first roundtable is really looking at what are the issues we were looking at. And so the participants were divided into breakout rooms to discuss possible policy. And really looking at how do we modernize newborn screening, because the core of the roundtables was asking the question of what are actionable policy solutions we can develop to solve these challenges. The challenges that I highlighted in the previous slide are ones that we have known exist within the newborn screening community for many years. We know what the challenges are. We know the innovation that is occurring now and in the future is going to further exacerbate some of those challenges. And so we wanted to make sure that we were getting past this idea of what are the issues and getting to the question of what are the solutions. And so the first roundtable was really getting to that idea of bringing the full public together and saying, what are some of the solutions we could utilize to address the challenges we know impact the newborn screening community. So then when we get to the second and third roundtables, we're really starting to narrow down. And so compiling a list of actionable solutions that came for the first, and then working with that collection of experts to better define and assess the viability of these actionable solutions. What can and cannot work? I'll talk a little bit about example of this when we get to the 4th theme around genetic testing, but really want to flesh out, okay, can this work? And if so, how's the best way to start moving that forward? And then once we're able to do that, in the final roundtable, really looking at, okay, we have all these actionable solutions. How do we prioritize around urgency, feasibility, and what can and cannot be done? So again, really looking at that idea of actionable. So the first roundtable was kind of bringing all the policy solutions to the table. The second one was really looking at the idea of what are the policy solutions that are possible. And the third roundtable is really getting to that word of actionable. Where should we be taking action, and where can we be taking action now? And so that culminated in 4 key themes. And so the 4 themes here, and I'm going to dive much deeper into all of these moving forward, but I want to take a moment so people can see the themes that we were talking about. Because we're going to dive into some of these issues specifically in terms of what the policies themselves were. But I want to ensure the fact that we know that we are looking at the federal aspect in terms of the leadership. We're looking at the use of a regional lab network. How do we address the data issue within newborn screening, as well as how we look at genetic testing? And so I'll dive right into the first theme. So next slide, please. And so you'll see here in the next few slides, what we're going to really focus on is the solutions that were proposed within the paper itself. And I know Bailey has posted within the chat the full paper. And so you can see within the paper all of these solutions, as well as some real world examples in which this is already being done and what we could build on moving forward. So within newborn screening, that first theme was really how do we increase federal leadership, accountability, and transparency within the federal newborn screening programs. Those three words, I would say we focus a lot on how do we picking those and making sure that we are identifying what that role is, because we know at the end of the day, newborn screening is a state-run program, but we also know that if we're making changes that are needed within the newborn screening system, the federal newborn screening programs need to have a large role in that process. And so the first is the idea of better defining the federal role within newborn screening, identifying the shared responsibilities among the various agencies, but also making sure that there is a clear leading agency. What we didn't want was a situation where you have the three main agencies, which are HRSA, CDC, and NIH, within newborn screening space, all looking to each other to take the lead and nothing moving forward. So we know they all do great work within the space, but identifying who would be kind of the leader, making sure that everything is moving forward as needed. I talked in the beginning around challenges for the evidence review process. That is something we have talked a lot about as a foundation over the last few years in terms of the RUS has its own limitations in terms of the ability to review conditions and how that review occurs. And so you can see here, we want to bring forward a few ideas of how to improve that federal evidence review. And so you can see here, it varies a lot as in terms of creating a full committee, which would allow for the ACHDNC to increase upon the 2 evidence reviews they're able to do currently a year, as well as changing how we're looking at the review itself when you look at the final bullet point of developing a path for screening conditions when a therapy is in development. So currently when you're conducting an evidence review at the federal level, you need to have an FDA approved treatment or care standard in place. And so having a conversation of can we have parallel tracks? And so it really gets to the idea of there is a limitation at the moment of not only how often reviews can occur, but what we're looking at in that process. And so we want to make sure we were identifying potential ways to move forward and really ensure the fact that the evidence review is keeping pace with the innovation occurring in the space. And so that's where you see with the bundling of conditions gets us the idea of how can we move faster without sacrificing the scientific and evidentiary requirements that are currently needed to be added to the RUS. And to that end, we also want to look at a additional solution. So this one was taking an innovative approach, looking at how do we address some of the funding challenges within the newborn screening review process. And so next slide, please. And so this was looking at a user fee program. And so many in the space are aware of the user fees that are used within the drug development process. And so the idea was to help secure stable funding for condition review process and adding new conditions to the RUS. At the end of the day, what we wanted to ensure the fact when we proposed this idea was we didn't want to get too far down the road because this was a brand new idea. And so you can see here the issues that still needed to be addressed. But the core of the proposed solution was creating a way that we can increase funding coming into newborn screening and the review process. We want to ensure the fact that this would not change how the review occurred in terms of the balance. We also want to ensure the fact that nobody would be left behind by adding this additional aspect. But we want to ensure the fact of understanding that there is money within the newborn screening space that can help to increase the frequency at which we're conducting these reviews. And we want to identify a way that it's been done in a different aspect of the healthcare space, again, with the user fee process within drug development, and see if it could be applied to the newborn screening space. And so this was a really innovative idea that still requires a lot of development, but we wanted to make sure that we brought it to the full community to initiate some additional conversation around this. Next slide, please. And so the second theme really looked at the regional lab network and the ability to support state programs. So this really gets to the idea of the challenges when adding new conditions to state panels. And we know it can be hard for each individual state to go through that process. And so we want to really build on the idea of creating a regional lab network whose roles could vary. And so the main proposal we want to talk about here was that second bullet point where federal support of flexibility and financing needed to support collaboration of the state within regional labs. This idea of, we know that regional labs should occur, that is something that's been discussed within the newborn screening space a lot, and we know they could do a lot of benefit, but how that's going to happen, it really still needs to be determined. And so it was acknowledging the fact that the federal government needs to have a role in bringing states together if you're going to create that regional network, and allowing those regional labs to identify what works best. Is it you have one regional lab who focuses on some of the pilot studies and so the development of these new conditions, or is it potentially having one lab focus on integrating new conditions to the state panels and then they share that across the board, as well as potentially having regional labs screen for other states? And so there was a lot of proposed solutions, but again, we'll talk a little bit about this in terms of limitations later. The experts at the table were approximately 45 experts. That is not the full community, and especially does not include the entire of the nation state lab directors. And we need to make sure that we're including everybody. And that's where, again, goes back to that second bullet point of the role of the federal government to bring all those stakeholders together and say, okay, this is happening. We know we need a regional lab network. What is the best way for us to get this done to ensure the fact that it will help improve newborn screening and not set us backwards? And so next slide, please. So the third area was looking at population level data. So within newborn screening, there is a need for a uniform system within the data collection process. There are so many data points within newborn screening that impact how states can implement conditions. It can impact how the ACHDNC looks at adding conditions to the RUSP. And so there needed to be a uniform system that's bringing all that together. And so that's actually, CDC is looking into this in terms of the Eden Project, which you can read more about in the paper itself. And so it's really building on that Eden Project and saying, how can we ensure the fact that we're uniforming the data we're collecting, as well as ensuring the fact that that data is being properly shared across state lines to ensure the fact that if state A has learned of the best way to screen for a new condition, that they can share it not only with state B, but state B through Z, and make sure that information is being shared across the country. Next slide, please. And so lastly, we talked a little bit about genetic testing and the integration of it within newborn screening. And so going back before where I talked about wanting to highlight all aspects of the system, this was something that really came up a bunch where we had state lab directors who would say, we love this idea. We know genetic testing can be beneficial. We just are unable at the moment to really add that to our capacities at the state lab. And so we wanted to make sure that we were talking to everybody. And so the really core idea that came out of this conversation, of this theme, is a need to coordinate a national study to determine effective and efficient avenue to integrate genetic testing. Again, moving past the idea of should genetic testing be included, that is, we know it's included today. We know its inclusion can continue to grow and really help newborn screening, but we need to make sure we're talking about it in a way of what is the best version of genetic testing to help serve the goals of newborn screening, what infrastructure and workforce capacity states need to further development to implement these conditions, and ensure the fact that we're having open and honest conversations in terms of what is needed to properly add genetic testing on a larger scale within newborn screening. Next slide, please. So quickly, just again, want to address some limitations. Again, we know this did not address all issues of the newborn screening. I put a few up on the slide in front of you, but we know there are multiple others. And so this is not meant to address all the challenges within the newborn screening landscape, but we did want to make sure that we were addressing some of them. And so that's why we were so excited about this white paper. Again, as I said, it was limited to approximately 45 participants, and we did not necessarily discuss specific funding solutions. And so we know funding is a challenge with the newborn screening, but there was a member of our planning committee who often said, newborn screening is receiving the most funding it has ever received, it still has these challenges. So we know we need more funding, and we know that's a part of helping to grow newborn screening, but we also know that there are challenges structurally outside of how much funding there is, and we want to make sure that we address those specifically. Next slide, please. And so in closing, we know the roundtables were a first of its kind opportunity to bring expert stakeholders together from a variety of backgrounds to discuss how to improve newborn screening within this country. And so we wanted to make sure that we were talking to everybody. And so you can see on the left side of your screen that in the last 20 years, there's been a lot of change around the newborn screening system. And so we know to truly modernize the newborn screening system, we need a multifaceted approach across the country to improve the entire system of stakeholders working together to really implement the solutions that we've talked about here, as well as the multitude of other solutions that were outside of the white paper. And so happy to answer any of your questions and look forward to talking more about this.
Great, thank you, Dylan. We have one quick question for you. Someone is asking what or who qualifies for newborn screening?
Not a stupid question. So that is a complicated question. I actually would encourage whoever asked to reach out to me. I'll drop my email in the chat because it is a longer answer. But the very general idea is you have to be able to screen for it in the general population, and you have to have a treatment or care standard in place. A common misconception is that you need an FDA-approved treatment. That is not true, but you need a care standard. There are a lot of conditions on newborn screening panels that are metabolic in nature, and so sometimes that is following a certain medical foods diet. And so you just have to have a treatment or care standard in place. Those are the two kind of overarching themes. There are a few others that really culminates into a net benefit conversation, but then we're really getting into the weeds, and that would be for a different conversation. So again, I'll drop my email into the chat. So I'm happy to go into more detail about that, but those are the two general ideas.
Awesome, thank you so much. We are going to go ahead and move over to Molly Ford. Like I mentioned before, our last two presenters are going to be sharing more information with you about current federal legislation that you can advocate for using the data and outcomes that Annie and Dylan have just discussed. So Molly, I'm going to go ahead and turn things over to you.
Okay, thank you so much, Caitlin. You can move to the next slide. So I am here to provide an update on the Access to Genetic Counselor Services Act. Obviously, the discussions of access to genetic testing, et cetera. A key component to all of that is to ensure that you have a provider with the genetic expertise to help interpret those tests, communicate them to the patients, the families, to help and work with the practitioner team, the physicians, et cetera, to implement, work out that medical management plan. So this, next slide, please. So this bill, introduced in both the House and the Senate, would authorize the Medicare program to recognize genetic counselors as providers. So right now, Medicare covers the service of genetic counseling for an array of applications. However, they do not allow genetic counselors to provide that service, largely because they don't have provider status. Genetic counselors are licensed in 35 states. Another handful of states are in the process of getting those bills passed. Practice Acts, scope of practice, all allow genetic counselors to practice independently. And obviously we know that access to services for genetic counselors is really important. And when you have to work under a physician, bill incident 2, et cetera, that gets to be problematic when you're trying to ensure that patients have a steady pathway toward a genetic counselor. And so ultimately, genetic counselors can see patients across the board independently. They can set up their own small businesses, et cetera, but they cannot see Medicare beneficiaries simply because they do not yet have provider status. This bill would provide that status fit. In terms of reimbursement, right now, they bill incident to physicians who are supervising them. And this bill would allow them to be directly reimbursed at 85% of the physician fee schedule. That would allow for 15% the cost savings that we are looking to make the case to the Congressional Budget Office when they do score this bill. Obviously, access is a huge issue here. When you have a huge portion, over 63 million Americans, many of whom would tremendously benefit from access to genetic counselors who are unable to readily access a genetic counselor, who have to go first through a physician, et cetera. That impedes access, that creates barriers. And as we know, Medicare populations already have a lot of barriers to getting to care. So this is one that we hope will be removed. And of course, obviously, with genetic counseling, someone who can ensure that the test is appropriately tests are appropriately ordered, but then that interpretation of those test results are appropriately understood, conveyed, et cetera, discussed. Counseling is provided, that you're going to get better outcomes from patients and from families. One big thing with genetic counselors is that they do this night and day. So it's not like they're handling a bunch of other different things in addition to the genetic counseling. This is what they do. So they do sit down, they do know, and they can take a third-degree family history. They can identify other members of the family who may need to be tested for from similar, just depending upon what the cases are, but those tests can happen and you can be more identified. So we always say that genetic counselors help ensure the right test is ordered for the right person at the right time. And obviously those all contribute to better outcomes. And then a really big part of this is that Medicare provider status would enable genetic counselors to provide telehealth services to Medicare beneficiaries. So even before COVID, when telehealth really became very relevant to the way that care is delivered in the United States, genetic counselors were providing care by telehealth, largely because you don't need a physical exam to provide genetic counseling. So that part is something that genetic counselors were way ahead of the game on. And of course, they can do this for all individuals except Medicare beneficiaries. So we call it an artificial access barrier that would be removed with this bill. Next slide, please. So HR 3876 was introduced June 6th, and we have accrued 30 co-sponsors since that introduction. We have a very nice balanced Republican Democrat, also representation from Energy and Commerce, Ways and Means, which is where this bill is currently being referred. Our champions in the House are Representatives Adrian Smith from Nebraska and Brian Higgins from New York. We are doing very well in the House. I think when we adjourned last December, we had close to 70 co-sponsors. So we are gaining momentum very quickly this Congress and are in the process of accruing support. So this is good momentum. Next slide, please. And then the Senate side, the Senate counterpart was introduced in mid-July. Senators Barrasso and John Tester are our champions there, both very familiar with genetic counseling and have been champions of our bill, of our efforts for a long time. Additional co-sponsors, Marsha Blackburn from Tennessee and then Tina Smith from Minnesota. Again, we're looking to build co-sponsors in the Senate. Our inaugural bill in the Senate was introduced last Congress. So again, a little bit behind that House bill, but we're really making the rounds and trying to get this in front of all the senators as possible. Continuing our outreach to previous co-sponsors in the Senate and as well as key members on the Senate Finance Committee. And right now we are doing, and mostly as a thanks, I suppose, to COVID, is that virtual calls are a thing in Congress now, as you all know. So we are doing a lot of constituent calls. So genetic counselors can join our calls from the comfort of their office, their home, et cetera. And that's very helpful to have that constituent, that genetic counselor on the phone with you to meet with the congressional offices, really make a case to help really paint a picture of the importance of this bill. We have over 270 genetic counselors who have signed up to participate in congressional meetings with us. So that's what we are working on and getting those scheduled both in the House and the Senate. And then, of course, we're working with NSGC has a series of genetic counselor volunteers who are helping to coordinate those meetings to encourage fellow genetic counselors to sign up for meetings and so that we can continue to meet with as many members of Congress as possible and as well as do very strategic follow-up to co-sponsors from last Congress to ensure that they get back on the bill. I'd say we have about 3/4 of them, but we're looking to get several more on there quickly. And I think most of them are in the process of signing on. Sometimes it takes a little while. We have a coalition that is a large group of organizations who are outside of NSGC who support this bill. Many of our groups that you're aware of are on this bill. Thank you so much. We have a lot of support from rare disease organizations, and we thank you so much for that. And we are working hard on your behalf too to get this bill passed. We do strategic outreach to our coalition, largely if they have their organizations have lobbying days or have lobbyists, et cetera, that this bill is a part of kind of their ask. And then when we have specific asks ourselves, such as sending letters to Finance Committee or trying to get our bill into a larger package, we tap that coalition, make them aware of what we're working on, getting the word out, et cetera. Next slide, please. Again, a little bit more about that coalition. We have 436 supporting organizations to date, 65% of ASCO state chapters. We've been active in previous RDLA Hill Days. Our focus really also is on hospitals, hospital systems, many of whom are on or who are engaging for this coalition. Hospitals right now, many of genetic counselors are employed by hospitals, especially teaching hospitals, universities, et cetera. One thing though is hospitals can't directly bill for genetic counselor services. So that's kind of another barrier here. So again, with the removal of incident 2, et cetera, enabling genetic counselors to bill for their services, we're going to be able to see a lot more hospitals hire, retain genetic counselors, which is helpful. Of course, you have genetic counselors on site to help patients who are actually there on site too. Last year, which is one example of some of the outreach we've done with the coalition, is that we were able to get 254 organizations sign on to a year-end letter, which is to sort of try to get our previous bill into one of the year-end packages. So we were able to really generate a lot of support and momentum there just from using our coalition. So we thank all the organizations who are active participants so much. And if your organization is not yet a part of our coalition but would like to be added, please feel free to email me here. I'm happy to get you added there. I know a lot of you are very familiar with this bill. If you're not, or if you have questions, please feel free. I can answer them, or my email here. Please feel free to send me emails along at any time if anything comes up too. Hopefully at the next update, we have more co-sponsors and a little bit more promising updates of where this bill will go.
Awesome. Thank you, Molly. We hope that people will take what they've learned about the bill today and do some outreach and get some more co-sponsors as well. We do have a question for you in the chat. Someone is asking, you mentioned coverage for Medicare for genetic counselors, but what about Medicaid?
Yeah, so this bill is specific just to Medicare. Medicaid is going to be across the board a little bit different, largely because each state has a little bit of a different coverage for Medicaid. So, but ultimately, Medicare, as you know, one thing is Medicare kind of provides the model for third-party payers for Medicaid, et cetera. So you're going to see this coverage happening with Medicare. You're going to see that happening with Medicaid a little bit more and third-party payers as well. So you're going to see a little bit more consistency once this bill is passed across that. But this bill specifically is just addressing Medicare.
Okay. Thank you so much, Molly. And of course, like Molly said, if anyone has any other questions, please take her email address off this slide and reach out. So we are going to go ahead and move over to Megan. Thank you so much, Molly. All right. So we have Megan Anderson Brooks from Innovation Policy Solutions, who is here to talk about the Precision Medicine Answers for Kids Today Act. So Megan, I will go ahead and turn things over to you.
Thank you, Caitlin. Well, it's such a pleasure to be here with you all today. As Caitlin mentioned, I'm here to talk about the Precision Medicine Answers for Kids Today Act, or ANSWERS for short, ANSWERS Act for short. That's less of a mouthful. I work at Innovation Policy Solutions. I'm the president there, but we have the pleasure of working directly with Invitae, which is a genetic testing company dedicated to delivering genetic information services and driving genetics into the standard of care to improve healthcare for all. So that's who I am here on behalf of, but I also want to acknowledge that there is a large group of stakeholders that have all come together to work on advocacy related to this bill. Invitae works very cooperatively with them, and I'm very thankful for everyone working together in this way. And that includes groups like the Personalized Medicine Coalition, Every Life Foundation, a number of other patient advocacy organizations, other laboratories, a biopharmaceutical company, et cetera, et cetera. And so I just want to make sure to note that we work very collaboratively, and we would love any of you all to join in those efforts in our advocacy work. Next slide. So I don't want to dive too deep into this issue because I know that you all understand the problems with the diagnostic odyssey deeply and intimately. And so I just want to note specifically that when we're talking about the problems associated with the diagnostic odyssey on the Hill, we're also specifically pointing out that on average, patients with rare diseases undergo up to 14 non-genetic diagnostic tests, often receive numerous misdiagnoses before they finally find their answers. And this, as Annie had described earlier today, this really contributes to clinical mismanagement and unfortunately takes away the opportunity to improve a patient's healthcare outcomes. And this is really in direct conflict with this general understanding of the importance of genetic and genomic testing. And so we're really thinking with regards to this bill, what are those barriers that we need to address to improve access specifically for Medicaid beneficiaries and kids who are under the age of 21. So a couple of things that have been identified is that there's a lack of clarity on insurance coverage. And specifically poor guidance from public payers such as Medicaid. And then also there are poor health outcomes associated with healthcare disparities and really that being a problem for underserved communities. So these are two of the barriers that the Answers Act is looking to address. Next slide. And so we are really lucky to have congressional champions who have been thinking about these barriers and how to resolve the barriers for a number of years now. For instance, Representative Eric Swalwell, a Democrat from California, had first introduced legislation in 2018 on the topic. And so, and we've really had a number of proposals that you've probably seen, bill names with a couple of different names. And so when all of the stakeholders that I had referenced earlier came together, we were really talking about how to effectively create and advance legislation to address these barriers. And so a topic that we spend a lot of time talking about is that there are a range of different types of testing approaches and why you would use single gene testing, panel genetic testing, or whole exome and whole genome sequencing really depends on the clinical context and what might be most appropriate for that patient. And we really want to leave those decisions up to providers. And we also want to acknowledge that there's still a number of reimbursement challenges associated with single gene and panel testing as well. And so we deeply wanted to see that the legislation addressed reimbursement challenges associated with all types of testing approaches. And we also wanted to be sensitive that there are advantages like a shorter turnaround time and lower costs associated with some of the testing, but also acknowledging that there have been incredible, wonderful advances with whole exome and whole genome sequencing that need to be acknowledged as well. So we're really talking about the diversity of testing approaches and making sure that's fully accessible to a patient as they're making decisions about what to do next when trying to get answers about their condition. Next slide. And then another topic that we spent some time talking about was this benefit that exists in Medicaid called the Early and Periodic Screening, Diagnostic, and Treatment Benefit. And we wanted to make sure that legislation didn't cause confusion with regards to what this benefit could potentially cover. And it could, and the way it reads is that it does cover diagnostic testing. So to back up a little bit, in case you're not familiar with this benefit, the benefit set are essentially federal parameters for what Medicaid must cover for all kids under the age of 21. And as the name insinuates, it includes wellness visits and screening, but it also includes coverage for diagnostic testing and treatments as well when it's medically necessary. And as you get into that, the devil's in the details. So we're really talking about there being a need for better guidance on what those federal requirements and recommendations are for diagnostic services under the EPSDT program, other than just simply requiring diagnostic services when medical necessary. So we're looking for a little bit more information on what that means. So moving to the next slide. So all of those conversations coming together and various proposals being presented over time really led to the introduction of this new version of the bill called the Precision Medicine Answers for Kids Today Act, which was introduced as HR 5989 in the last Congress. And we are thrilled for the three sponsors listed here to come together to introduce the bill. That includes Representative Eric Swalwell that I mentioned earlier, his colleague from California, Scott Peters, also who has been a wonderful and tremendous champion on this topic. And they were joined by Representative Tom Emmer, a Republican from Minnesota, who at the time was a House co-chair with Representative Swalwell on the Personalized Medicine Caucus. And so next slide, where are we in the 118th Congress? Oh, I'm sorry. Let's talk about what the bill does, first of all. So, no, you were fine. Sorry, Caitlin. So turning to the next slide, to talk about what the bill does. The bill does several things. First, it requires CMS to issue guidance to states on a number of topics. The first topic being on the coverage of genetic and genomic testing diagnostic services, including the full range that I had talked about earlier, including making sure that we're not prohibiting or limiting that list. And so talking about coverage under the EPSDT program. The second topic, providing education and support to providers to minimize denial of claims for medical assistance under the state plan. And third, wanting to make sure that providers and Medicaid eligible families are aware of the EPSDT program. The second large topic that the bill would do is it would create a 3-year demonstration program for up to 15 states, prioritizing those that have underused genetic and genomic sequencing clinical service for pediatric patients that have been undiagnosed. And so, really, even though it is, we're trying to clarify that it's already covered. We're trying to ensure that states who have not done a good job of providing coverage have a funding and tools available to them to solve some of the challenges with getting with providing access to genetic and genomic testing services. The third thing the bill would do is it requires CMS to issue a report on Medicaid state-by-state coverage of genetic and genomic testing services. And there's some information in there about to detail what is happening state by state, so we can start to better understand what the challenges have been. And then lastly, and importantly, it requires a National Academy study on access to genetic services, especially in underserved and marginalized communities. So getting now into what happens and what's happening in the current Congress, I wanted to let you know that we are working hard, next slide, to get the bill reintroduced. Representatives Swalwell and Peters have committed to reintroducing the legislation in the House, and we're working to identify Republican members to work with them to champion the legislation. And you may be familiar with the fact that Representative Emmer has taken a step back from sponsoring legislation because he's now in a leadership role. So it's very typical. The office continues to be very supportive in the background. But yeah, it's very typical for them to do that. So we've been working on, and we're having very productive conversations on who those Republican members might be to join Mr. Swalwell and Mr. Peters. And then also we're working with sponsors of another bill in the Senate. And so this bill was sponsored by Senators Susan Collins, Mark Kelly, and Robert Menendez. And this bill was a very similar bill. As I said, there's been a number of proposals that have been introduced that you might have heard of, but this similar bill is more specifically focused on whole exome and whole genome sequencing, and we're working with them to try and introduce a similar bill to the House version of the bill that is broader. So next slide. And very quickly, something that you can do to help is if you're in a position where you can have your organization endorse the Answers Act, we would love for you to join our efforts in supporting the legislation, and additionally joining our efforts to identify champions in the House. And if you happen to be speaking with Senator Collins, Menendez, or Kelly's offices, please ask them to introduce the Answers Act. We've talked with them many times, and I think there's some strong interest, and we're trying to get everyone on the same page. And so we would love for your voice to be added to that conversation. And lastly, the Rare Disease Caucus is so tremendous and active and powerful, and really appreciate their focus on the rare disease community. But I also want to let you know that there's a Congressional Medicine Caucus as well. So if you would love your member of Congress to join this caucus and focus on personalized medicines and all the things that come with enabling access to them, that could be another request. And so I left my email there on that final slide, and I'm happy to share any other information that you might need. And thanks for your time.
Great, Megan, thank you. We have two quick questions for you.
Sure.
The first question is, what are, if any, objections to this bill when you are speaking to members of Congress?
I don't think we have any objections to the bill. I think it's the fact that there have been a few different proposals, and now we're just trying to get everyone on the same page. You know, there is so much excitement about whole exome and whole genome sequencing. So wanting everyone to take a step back, and we're excited too. I'm excited. But we really want to make sure that patients, you know, for instance, if it's more clinically appropriate for them to have a single gene test and they can get that answer faster, that's an option, and the other forms are not being being prioritized because we haven't addressed the reimbursement challenges for those other forms of testing as well. Yeah, please join us in helping get everyone on the same page.
Amazing. Next question is, how would states apply for that 3-year demonstration that you mentioned?
Yeah, so it's through a particular kind of waiver called a 1115 waiver, Medicaid waiver. So it would be through that particular kind of waiver, and Medicaid would approve this pilot project, and it would be the state applying to work with them for a proposal to expand access to genetic and genomic testing. And I'm happy to share more information about that application process if it's helpful.
Great. Thank you so much, Megan. Those were all the questions that we had for you. But of course, with that last question, if anyone has any follow-up, Megan's email address is at the bottom of the screen here. I will give you some time to get that copied down very quickly. And I see a few questions in the chat about the slide deck. We do record these webinars, and the recording will be made available on the RDLA website. All right. We have our lovely state advocacy manager, Kinley, here to give you all a quick update about our upcoming state advocacy days.
So much for joining today. I just wanted to give you a quick update on our state advocacy date. It's going to be in Columbus, Ohio on October 17th. If you are a Ohio advocate, or you know of anyone, we'd love for you to share this information or register. Registration closes on October 2nd. It's going to be a great event. We're going to cover these 3 legislative asks that you see on the screen. Please don't hesitate to reach out to me with any questions, and we will hopefully see you there.
Great. Thank you so much, Kinley. And just want to give you guys a quick reminder that our next RDLA webinar is going to be on Thursday, November 16th. So be sure to save the date for that. And then, of course, if you have not already signed up to receive our newsletter, you can do so at rareadvocates.org. This newsletter provides Capitol Hill updates, state policy updates, resources for the community, and free events for the community. So it is a great way to stay in the know about everything that is going on within the community. And then, of course, we have our social media handles here. We encourage you all to follow us again to keep up with all of the different things that are going on. And if you have any questions about RDLA or things that were covered on today's webinar, I encourage you to reach out to myself, Caitlin Laws. My email address is listed there, or our Senior Director of Advocacy, Shannon Von Felden, and her email address is listed as well. Very quickly, before we log off, thank you to all of our webinar sponsors for making this webinar possible, And thank you to all of the speakers who took the time to come and present on this very important information for Newborn Screening Awareness Month. We look forward to seeing you all next month. Have a good one, guys.